So we have that 38-year-old being presented to our hospital 20 minutes after sustaining the multiple stab wound allegedly caused by the knife. On arrival to our hospital, on arrival to our hospital, he was conscious, but he was restless, with cold peripheries, non-palpable peripheral pulses, and non-divertible blood pressure, with heart rate of 150 per minute on monitor, respiratory rate of 34 per minute, with non-recordable saturation via pulse oximeter. On examination, he had multiple penetrating wounds on the anterior chest with active bleeding from the wounds. So, how to manage this patient? So, if this patient comes to nursing home, if this patient comes to medical college, and if this patient comes to corporate trauma center or an emergency room, all the three units are going to manage this patient differently. In India still, because I have worked in all three types of setup, and I have seen that all these patients will be managed.
તો કેવું છે કે આપણે એમડી ના કરિયર થી લઈ અને જ્યારે રિટાયર્ડ થા સુધી આ કેસ કોઈ બી મેનેજ કરવાનો આપણે આવતો નથી.
એટલે નર્સિંગ હોમ માં આવે ને તો સ્ટેટ ફોરવર્ડ નથી લેતા જાવ
સેમ પેશન્ટ
અને ફોર્ચ્યુનેટલી પબ્લિક માં એટલી સમજ છે કે આ મેડિકલ જેમાં મેડિકલ વાળી જે નર્સિંગ હોમ આવે
નહીં મને આવે જ નહીં
પબ્લિક અવેરનેસ
રાઈટ. હવે તમે કરી છે મહેનત તો બોલી દો, અમે સાંભળી લઈએ. ચાલો આજે સ્ટેપ પોઈન્ટ પર.
So for this, there is a very good program is ongoing to manage this type of patient. It is advanced trauma life support, which is endorsed by the American College of Surgeons. This is very costly course. It will cost around 28,000 to 32,000. It is full 5-day course, and this type of patient when used to come in our corporate setup, emergency medicine residents will jump to manage this patient. They will rather less enthusiasm towards managing the sepsis patient, but this trauma patient comes, they will do each and everything possible. So, history of ATLS was started when one orthopedic surgeon himself was piloting via plane and crashed in the rural area in 1976. The surgeon sustained serious injury. 3 of his children sustained critical injury, and 1 child sustained minor injury. His wife was killed instantly at the place. He and his family was received a care at the area, and then after recovering from the illness, he stated that when I can provide the better care in the field with limited resources than what my children and I received at the primary care facility, there is something wrong with the system, and system needs to be changed. So he was બરાબર ઠારો તો તેના ભાઈબંધી સામે. So Dr. Ronald Craig, his friend, he was a family medicine. He suggested that you have to train them before you blame them. So with the help of Dr. John Upright, he was a pioneer in conducting the AHA ACLS course, and they developed a trauma protocol with emerging data, simplicity and practicality. So they have first formulated the first ATLS, and they have started to teaching in 1978 in local units, and then it was adopted by the American College of Surgeons, and it is now widespreadly taught everywhere.
આ તો હિસ્ટ્રી બરાબર છે, સાંભળવાનું જાણવા પૂરતી, પણ એવિડન્સ બેઝ મેડિસિન માટે આ છે. બાકી ટ્રોમા તો ચરક ને સુસુક ને એ બધા બી કરતા બ્રેક, બરાબર. એટલે ઓલવેઝ કીપ ઇન માઇન્ડ. આ તો આપણે આ બુક વાંચીએ છીએ એટલે, બાકી આની બહુ પહેલાથી ટ્રોમાની ટ્રીટમેન્ટ થતી.
No, the underlying concept of ACLS program was that it was initially very difficult to accept. So basically there is 3 concepts of ATLS. To treat the greatest threat to the life first. Okay. Never allow the lack of definitive diagnosis to impede the application of an indicated treatment. And the detailed history is not essential to begin the evaluation of patient with the acute injury. So before starting developing this program, there were also trauma was also managed like a medicine history. They were also doing head-to-toe examination. They were also managing all the peripheral examination, and then they came to a final diagnosis, and then they will send the investigation, and then they will start the treatment. And by that time, very much precious time was losing. So basic principle of developing the ATLS was they were managing standard trauma care, but they have protocolized the standard trauma care into the one protocol manner, systematic manner. So this program was started, and this program's goal was assess the patient condition very rapidly and accurately. And after assessing, you start the resuscitation and stabilize the patient. Then determine that this patient requires my expert, or I am unable to provide care to this patient, and refer this patient to the appropriate facility and arrange appropriately transfer to the inter-hospital transfer, and ensure that the optimal care is provided during the level of care does not deteriorate during any point of time of evaluation, resuscitation and transfer process. So there is a tri-modal death distribution in trauma. First week usually occurs on the spot within second 2 minutes. The apnea happens due to severe brain injury or a high spinal cord injury, rupture of the heart, aorta or large vessels. Only prevention can reduce this type of trauma-related death. Seatbelt application and higher safety standard will improve this type of death. Second peak is minutes to several hours after injuries. So this is the golden hour of trauma. In this type of second peak, patient expired due to subdural hematoma, epidural hematoma, pneumothorax, ruptured spleen, laceration of liver, pelvic fracture, multiple other injuries. And third peak usually occurs after once the patient stabilized, sepsis or multi-organ related issues that happens usually after weeks. So for the golden hour of trauma, second peak is important. So they have protocolized this initially management and evaluation of trauma. So what are the basics of trauma assessment and management? So first is primary survey and resuscitation. So you do a primary survey and simultaneously you start the resuscitation. Don't wait for the definitive diagnosis. Then there are some adjuncts to the primary survey. You can send some investigation. You can use some tools to come to a presumptive diagnosis. Then again re-evaluation of the primary survey each point of time. Then after that there comes a secondary survey with adjuncts. Then there comes after secondary survey we think that this patient is having a chest injury. I am not going to manage in my corporate hospital even if I can manage. So I will send it to the hospital where there is a thoracic surgeon is available. So before sending to the thoracic surgeon, I have to manage this patient for a specific care. And there is a definitive care. So all the trauma is, initial management of trauma is based on the primary survey and simultaneous resuscitation. So what are we including in the primary survey? Initially, primary survey was also only including ABCD. Now they have included exsanguinating hemorrhage. So once there is a exsanguinating external hemorrhage, like a patient is amputated and there is a active spurting from the femoral artery, then we need to stop that exsanguinating hemorrhage first. Then we go for the airway assessment and management. So then there comes a breathing. There comes a circulation. There comes a assessment of disability. Then there comes a assessment of exposure. So if we go in this manner of assessing the trauma patient, there are very high chances that we give utmost care to the patient, and there are very high chances that we prevent disaster. And these are some adjuncts to the primary survey. So while we are doing this primary survey of airway, breathing, circulation, disability and environment exposure, we are allowed to send some reports like arterial blood gas analysis is included in primary survey. Then E-fast for focus assessment sonography in trauma is included in primary survey. Two types of X-ray, one is chest X-ray and one is pelvic X-ray. Two X-rays are also included in primary survey and ECG monitor. So you can use these modalities and simultaneously manage the airway, breathing, circulation, disability. Then you can come to will come to identify the greatest threat to the life very first.
टेस्ट सेक्शन में पहले से एक्सरे करता सीटी चेस्ट में सीटी एब्डोमेन जैसे ना आपको बहुत फास्ट हो जाएगा.
Sometimes the patient is very critical, so we cannot shift the patient to the.
So people will also CT lagi na de.
If we so and what is this whenever this type of guidelines is made, ETLS or SLS, they focus that these guidelines are replicable to the
टेस्ट सेक्शन में पहले एक्सरे देवाना कितना convenient हो जाए. That is what I mean.
આ બધું કદાચ થિયોરેટિકલી સારું લાગે છે પણ પ્રેક્ટિકલી કરવા
Yes.
જવું પ્રેક્ટિકલી ઇમ્પોસિબલ છે.
If faster than patient intubated હોય તમે CT
It is very bad.
Okay, that will give you other just go to because જેટલો chest X-ray ને pelvic x-ray લેવામાં સમય થાય ને એટલામાં તો આખો
પ્રેક્ટિકલી કદાચ
ટેસ્ટ એક્સરે પોર્ટેબલ થઈ જાય ને બેડ સાઈડ પેલું તમારે ત્યાં લઈ
X-ray
જવું
is very portable. We can simultaneously resuscitate the patient, and for CT scan we need to CT scan
Or-
very few hospitals having the same floor CT scan in ICU or emergency room.
પોર્ટેબલ સિરીઝ બી આવી ગયા છે
patient
પણ
બધા ઇમરજન્સીમાં આવે ને ત્યાં પેલો અસેસમેન્ટ થાય ને ત્યાંથી થઈને સીધું પેલો જોડે જોડે રિસર્સિટેશન થાય ટીમ રિસર્સિટેશનની ટીમ હોય અને એ રિસર્સિટેશનની ટીમ કરતા કરતા સીટી સ્કેનમાં લઈને સીધા ઉપર લઈ જાય
જ્યાં આટલી ફેસિલિટી હોય રિસર્સિટેશનની જ્યાં સીટી સ્કેન કદાચ હોય
logically speaking that will give more information rather than
What are we going to diagnose from the CT scan?
CT સ્કેનમાં તો અલ્ટિમેટલી કોઈ તે bleeding
We are going to diagnose bleeding in the chest cavity, or we are going to diagnose bleeding in the
pneumothorax
that can be easily diagnosed via sonography bedside and X-ray.
કન્વીનિયન્સી તમે આ પેશન્ટને જ્યારે આટલી બધી ઇન્જરી થઈને ચેસ્ટ એક્સરે પેલ્વિક એક્સરે
No, I will not shift my non-palpable, non-recordable blood pressure patient.
સર 4-6 કલાક 10 કલાક પછી કદાચ હજી કરી શકે નહીં બસ પણ આ ઇનિશિયલ અવર્સની વાત આવે છે
But CT scan is done before we start a definitive care. So accentuating external hemorrhage. Accentuating external hemorrhage can be stopped by two methods: direct pressure with the gauze application, where we cannot apply a tourniquet, and then there is a tourniquet application. So this hemorrhage only qualifies that if there is a large volume, active and continuous external blood loss. If we are not going to stop large volume, continuous active blood loss, whatever we are going to resuscitate this patient will not going to die. So if patient is having the amputation of hand or amputation of limb, we have to apply tourniquet. So we have to apply tourniquet to the proximal area of the amputation. We need to register a time when we apply the tourniquet. Tourniquet should be applied in a pressure that it should block the arterial supply. Arterial supply also. That's only then only we are going to stop the bleeding. And simultaneously after applying the tourniquet, we are going to manage the tear. This is not going to, if any bleeding in scalp and we are going to manage scalp bleeding, this is not like this. If any life-threatening, active life-threatening external hemorrhage,
bleeding from limb on
from limb, yes, that is we are going to experience. Airway maintenance.
કેટલું પ્રેશર એટલે તમે કઈ રીતે જજ કરશો?
So external loss is we are seeing that patient is losing activity. So we are applying the tourniquet, and when this
બ્લડ આવતો બંધ
blood is going to stop.
That is not
Yes,
a technical.
we have to, yes, we
આ
have to,
કરીએ છીએ કે વિદેશી નહીં
no, no, we
જ્યાંથી
have to,
સ્પોટ થતું હોય
we have to stop the external bleeding.
આર્ટરી બંધ થઈને રિનસ તો ઓલરેડી થઈ જ ગઈ હોય
There are chances of limb ischemia, but saving the life is more important. And we can get a time that we can shift to the patient, and they can eventually do the definitive treatment. So airway maintenance with restriction of cervical spine motion. So airway maintenance is one thing that airway is most important. We have already taken separate class on how to assess the airway in ICU and critical care. Simple assessment is if patient is able to communicate, if patient is able to tell his name or he can recollect the event, then his airway is better. So this is only 5 seconds or 10 seconds we are going to manage that. Yes, patient is going to patient is saying is there.
એનો સ્મોલ પાર્ટ તો આટલા બધા પેનમાં હોય છે
So
કઈ
his
કરો
airway
કઈ
is
કરો એટલે એ તો બોલતો જ હોય એમ
So his airway is patient. Airway is not the immediate threat. So airway is not the immediate threat. We do not want to do not need to intubate this patient right away. So we can move on to the second step. Okay. So all the trauma airways are difficult airway. One important thing is whenever there is a traumatic brain injury, there are chances that patient will have a cervical spine injury. So Philadelphia collar is must in this type of patient. If Philadelphia collar is not present to our hospital, then one of the staff should have to do manual inline of stabilization of cervical spine. So they are also teaching us how to do a manual inline stabilization in AT response. So there are indication of definitive airway. Definitive airway is defined as a tube placed inside the trachea with cuff inflated below the vocal cord with this tube connected to the oxygen enriched assisted ventilation. So definitive airway is three type of definitive airway: orotracheal tube, nasotracheal tube, and surgical airway. Okay. All others are supraglottic airways that are not fitting into the guideline of definitive airway. Indication of definitive airway: one is risk of bleeding or aspiration, vomiting, laryngeal, facial-maxillary trauma. One is acute neurological deterioration like GCS less than 8. If patient is not bleeding but patient GCS is less than 8, then we need to secure the airway of this patient as a definitive airway. So this is some flow chart for the rapid sequence intubation. This we have already discussed in our airway program. Only one thing is important, that if you can't intubate and you can't ventilate, so patient is unconscious, you can insert the oropharyngeal airway, and after inserting the oropharyngeal airway, you can buy some time with the bag and mask ventilation. If you cannot do bag and mask ventilation also, then you have to go for the cricothyroidotomy. So in ATLS, they will also teach you how to do an emergency cricothyroidotomy. One station is there. You have to identify the thyroid cartilage and cricoid cartilage. Between this thyroid cartilage and cricoid cartilage, there is a cricoid membrane. You will do a transverse incision on the cricoid cartilage, and on this, after putting a transverse incision, you will use the blunt end of scalpel. Another end of the scalpel, you introduce that blunt end into the opening, and you rotate that blunt end, and it will create an opening inside the trachea. And after creating this opening, you will insert the boogie, and you can insert the 6 number of tracheostomy tube inside this cricothyroidotomy. So if it is very urgent, you can do a cricothyroidotomy. Initially they are also teaching the needle cricothyroidotomy, which is more easy, but it is in this edition of ATLS, they are only focusing on the surgical cricothyroidotomy. Nowadays, many institutes have a surgeon available. They do fast surgical tracheostomy than a cricothyroidotomy. So then you can go for surgical tracheostomy. That is also.
Sometimes intensive start doing faster than surgery.
મોટે ભાગે અત્યારે તો
મોટે ભાગે
ઇન્ટેન્સિવિસ્ટ એવું છે ને સર, કરી બધું શકે છે પણ કરી શકતા કરી લઈએ એવું બી હોય છે. A continuous reassessment. So after intubating the patient or assessing the airway, patient is again become the hypoxic. So you start from the basic, again you start from the examination. So this is low pneumonic, any endotracheal tube is displaced, any mucus plug is there or kinking in tubing. You have patient is already having simple pneumothorax. You intubated the patient, you have positive pressure ventilation, and this simple pneumothorax become tension pneumothorax. That also happens. And there is equipment failure. આપણે ઇન્ક્યુબેટ કરી દીધું, વેન્ટિલેટર લગાવી દીધું, આ બેન પાછળ ઓક્સિજન કનેક્શન લગાવવાનું ભૂલી ગયા, એવું બી થાય છે ઘણી વાર. બધાના લાઈફમાં એક વખત તો થયું હોય છે, એટલે એ પણ પોસિબલ છે. એટલે જ્યારે બી હાઇપોક્સિયા થાય તો વી અગેન ગો ફોર ધ ડોપ મ્યુટિંગ. So this is for the airway. Then comes the breathing and ventilation. So with airway, breathing and ventilation is also important. Breathing and ventilation also requires good function of lung also, chest walls also, and diaphragm also. So for assessing the breathing and ventilation, we have to expose the chest of the patient. Then we have to inspect the area. We first inspect the neck area for GVT distension. Then we inspect for any external chest injury like rib fracture or contusion. Then we see any abnormal movement in the chest, like one side of chest is not expanding as we are expecting, or there is a paradoxical movement of one side of chest. That will suggest that patient is having trial chest. So this is inspection, and after inspection there comes a palpation for palpitations, and there comes a percussion, but percussion is not going to help in emergency. So we can directly go for the auscultation. So with auscultation, what we need to see in this patient, decreased breath sound or decreased air entry. So there are three emergency in breathing and ventilation. One is tension pneumothorax, one is massive pneumothorax, and third is open pneumothorax, and some tracheal and bronchial injury. So during the breathing and ventilation assessment, we need to identify that if patient is having a tension pneumothorax or a massive pneumothorax or a open pneumothorax, and we need to treat that before going to the circulation. We need to identify this and treat that. We can use E-fast, extended fast during assessment of breathing and circulation. So for pneumothorax, we put pneumothorax and hemothorax, we put a probe and we can identify that patient is having a fluid in the pleural cavity, or there is a absence of lung sliding, and barcode sign is there for the pneumothorax. So primary survey, you identify these three problems and you get away with, because these are the first line to the threat. Then other things like simple pneumothorax, trial chest, you need not to identify in the primary survey. So this is tension pneumothorax. There is a ball valve air leak occurs. No any external slippage of air, and lung is going to collapse. And we need to identify if there is a midline trachea is midline or it is deviated to the opposite side. So in tension pneumothorax and hemothorax, there are two major differences for examination. In tension pneumothorax, you are going to find a elevated GVT on the same side, due to increase the intrathoracic pressure. But in massive pneumothorax, you are also going to have a decreased air entry on the same side, but GVT will not be elevated because patient is already losing blood, so patient will be in a hypovolemia. So this is major two difference clinically in tension pneumothorax and massive pneumothorax. So if you are having a tension pneumothorax, what you need to do? You find the largest needle available with you, insert that needle into the fifth intercostal space at the wherever there is a tension pneumothorax, attach that needle to the air seal mechanism, and you convert this tension pneumothorax into the open pneumothorax, and you get an expert help at that time. And once the expert help is arrived, you can do you can convert this tension pneumothorax into the tube thoracoscopy. You can do IC. Okay. And there are if we are not able to do ICD, then there are some pigtail catheter are also there. Many persons are very proficient in introducing central line, so they can same way they can introduce the pigtail catheter inside the chest cavity. They do the puncture, insert the guide wire. After removing the guide wire, they dilate the cavity and they introduce the 14 number or 16 number catheter. That will also serve the purpose for the temporary reason. And once it is done, you can have your help from the surgeon or from another person. We will do the ICD. Then there is open pneumothorax. Open pneumothorax is a open wound. There is a equilibrium between the intrathoracic pressure and extrathoracic pressure. So all the air will suck from the wound inside the chest cavity. So we need to apply this type of tap on this open pneumothorax. We need to cover this wound from the three sides and need to open this wound from the one side. So it will create a flutter movement. So air will not go inside, and with expiration air will come outside. This open pneumothorax will not convert into the tension pneumothorax. And you can also do ICD in this type of patient, but the insertion of ICD should be insertion side of ICD should be different than the wound side. Then there comes a circulation and hemorrhage control. So SWOP is defined as the insufficient oxygenation and tissue perfusion. Hemorrhage is the predominant cause of reversible death after injury. Once the tension pneumothorax is excluded by breathing and patient is still hemodynamically unstable, patient is in shock, then you have to consider that there is a blood loss. So rapid and accurate assessment is essential. You need to identify level of consciousness, skin perfusion and pulse. So tachycardia, low pulse pressure, anxiety, irritable mentation and cold and clammy peripheries. These are enough to diagnose shock. So this will also take 30 seconds to diagnose this if patient falls into which category. So if patient is having a heart tachycardia, systolic blood pressure unchanged or decreased, pulse pressure is decreased, there is a catecholamine surge and there is an increase in the diastolic pressure, the pulse pressure is going to decrease. There is an increase in the respiratory rate to increase the demand of patient's oxygenation and metabolic. On level of conscious, anxiety is the first sign. Anxiety and agitation is the first sign for any shock. Then we have sent the image. So going to take time before you diagnose that this patient is bleeding. Hematocrit is also going to take time before you diagnose this patient is bleeding. So first sign is acidosis. Development of acidosis and development of elevated lactate is the first laboratory parameters that you can think that this patient is in a shock and we need to manage aggression. So in moderate and major type of shock, we are likely to give blood products. So once the patient comes, I will start the normal saline or inhaled lactate 1 liter. Patient's hemodynamics will improve. So it will denote as a response to the resuscitation. So it is a transient, it is a sustained response or a transient response. If patient is having a transient response, means patient is still actively bleeding from some side. And in major shock, there is no any response to the shock. And from the transient response of fluid resuscitation, patient will require operative control likely. So these are the 5 sites where you can find the blood. So there is a mnemonic, 1 on the floor and 4 more. So 1 on the floor is external hemorrhage and 4 more is you can find the blood inside the chest wall, peritoneal cavity, pelvic cavity and long bone fracture. Okay. So thoracics we have a massive pneumothorax, pelvic we will have a injured vessel and it will have a peritoneal blood. Pelvic fractures is very most notorious because we are not going to identify with any of the bedside manual. So we need to do a examination of pelvic cavity and pelvic X-ray is important. If there is a open book fracture of the pelvis, it means there is a large amount of blood was in the pelvic cavity because it is retroperitoneal. We are not even going to identify from the E fast. And there comes a closed bone fracture. So femur fracture will lead to approximately 1 liter to 1.5 liter of blood loss, and radius and tibia fracture is related to up to 750 ml of blood loss. So that is also not a small amount. So how to identify where is the blood? So this is for fast assessment, focus assessment with sonography of trauma. Traditionally we are using 4 views, which is used by that is abdominal probe or USG probe. We are putting this probe in the 4 side. One is this right upper quadrant. So we are putting right upper quadrant. We are going to get images like this. Your liver and kidney are going to be side by side. This is Morrison's pouch, and you will, if patient is bleeding, this is the earliest sign you will get a free fluid, and here you are going to black color thin rim of fluid. Like this is hard, you are getting a black color fluid in LA and RA. Same fluid you are going to get in between liver and kidney. Same you are putting the sub-Z4 view. With sub-Z4 view you are going to diagnose a pericardial effusion or a tamponade. Same, then third view is left upper quadrant. So left upper quadrant is same. There is no space between the kidney capsule and spleen. So if you are going to find a thin rim of fluid between this kidney and spleen, you have a pelvic bleeding. And then fourth view is pubic view. You see a thin rim of fluid in the rectovesical or rectovaginal fossa. So these 4 are very primary important view. You can find that this patient is having a bleeding inside the peritoneal cavity. If patient is bleeding fast, if we are finding that this patient is having a bleeding inside the peritoneal cavity, so we are stating that this patient is fast positive. So if patient is fast positive and patient is hemodynamically stable, so there comes a role of CT scan. Then we send this patient to the CT scan to identify where this patient is bleeding. If patient is fast positive, grossly fast positive, patient is hemodynamically stable, not responding to our fluid resuscitation and blood resuscitation, then we can immediately go for exploratory nephrotomy as per guideline. But in our setup we can do, but in corporate they will always go for CT scan because CT scan is always available on the same floor, some like in an emergency. So they can do a CT scan before operating procedure. But one pitfall of CT scan is you need to do a contrast CT scan to find where is the patient is bleeding. Now you have injected the contrast, and after injecting the contrast, at same time patient is not bleeding at the same site. Sometimes happens in obstetric hemorrhage after LSCS, patient is having a hemorrhage inside the peritoneal cavity. We know that patient is bleeding from some side from the uterine cavity. We do a CT scan, and 50% or 60% CT scan comes inconclusive, because at the same time you introduce the contrast, patient might not be bleeding, and you will be falsely in a sense that patient CT scan is negative, I cannot operate. It happened to me one or two times.
Open and check.
So the open and check is the best method. So this is our patient that came to us at the 11:30 p.m. in midnight. Patient has a right parasternal wound, left parasternal stab, and one stab wound on the right upper zone. So patient's airway was patent. Patient's breathing and ventilation was compromised due to pneumothorax or massive pneumothorax with compromised circulation. Circulation was compromised, which was suggested by the agitation. Patient was very agitated and anxious. Patient has a tachycardia on ECG and cold and clammy peripheries. Immediately to large
What was his JVP?
Huh?
JVP.
Patient's JVP was not elevated. Everything was empty. Every system was empty. So immediately two large bore cannula was taken in the emergency, and 1 liter of fistulus was started. We have sent initial investigation which suggestive hemoglobin of 7.
क्या वेनस एसएस क्या लगा लिया?
हाँ?
वेनस एसएस क्या लिखा है?
Venous I think.
वो तो नहीं पल्स के सब
Pulse test also, but venous access was we have taken impact.
Pulse.
It was very difficult.
रियल मेरे का जो लार्ज बोर मार्टे
This is very important that we have taken 3 veins in this patient. One is right hand, one is in left hand, and I was want to see some another patient. Actually, I was fortunate, or patient was fortunate. I was gone to hospital to see another patient, and this patient come same time into the emergency. So immediately we have taken.
वेनस एसएस
So we have taken a most difficult task was to maintain that venous access, because patient was profusely sweating, and no other means we are going to maintain that venous access, and the patient was very agitated, so he was moving all fours, and it was very difficult at that time. So what emergency we have taken a large bore venous, and after shifting to the ICU we have taken central line also and taken artery line also. Femoral. So this was the initial X-ray. We have taken patient to in the ICU. So this X-ray we have done, it is not ideal quality of X-ray, and this X-ray is not typical for the hemothorax, but we can find that there is a good amount of haziness on the right side, and we have done a fast that I was talking, and it was showing that there is a fluid inside the pleural cavity. So we are suspecting that pneumothorax, and Vipul sir was also nearby to the hospital, and so he also came within 10 minutes. I have called sir to that sir patient has arrived, and this is this type of thing, and he also reached to the hospital within 10 minutes. So our patient falls into severe degree of hemorrhagic shock. The goal of management is restoring the blood volume as well as the stop bleeding. So initial fluid replacement of choice is destroyed. So excessive fluid replacement should be avoided. So you cannot only replace the fluid levels. Anyway, fluid is going to dilute the coagulation factor. Fluid is going to create a hypothermia, and it will lead to the coagulopathy. So we need to transfuse the blood. So there is a massive transfusion protocol. Massive transfusion protocol is designed to prevent the disasters. So it is a systemic, predefined hospital protocol for the rapid delivery of the large volume. It is designed to restore the circulatory blood volume, increase the oxygen carrying capacity, and coagulation factor to avoid the lethal triad of hypothermia, coagulopathy, and acidosis. If your trauma patient is having hypothermia, coagulopathy, and acidosis, it is the lethal triad. We need to prevent this. If these three sets in, we are going to lose the patient. So we need to act before this happens. So different criteria to activate this massive transfusion protocol. More than 10 units of PCV are going to require in adult in within 24 hours. So this is a retrospective criteria. We cannot wait for the 24 hours. So 24 hours માં 10 PCV જશે ત્યારે હું MTV ચાલુ કરીશ એવું ના possible. So then there is some another criteria like 4 unit of PCV is going to require in 1 hour. 50% of blood volume is going to require in 3 hours. Then clinical judgment of uncontrollable hemorrhage. I am treating physician and I will judge that this blood hemorrhage is not going to stop unless we do the hemorrhage control, definitive hemorrhage control. So we need to start the MTP. And penetrating chest trauma in hypotension usually requires massive transfusion protocol before hemorrhage. So balance resuscitation, common ratio is 1:1:1. We are 1 PCV, 1 FFP and 1 platelet. Usually one pack of most of the corporate hospitals are having a predefined MTP packet in their blood bank. So what they do, if patient of trauma comes, they will have like we have a code blue in our EC hospital, they will have a code MTP in their hospital. So once they activate the code MTP, one person from the blood bank will come with that blood bank with him. Then pathologist will come on site. Then surgeon will come on site. Everyone will reach to the one place. And one pack usually consists of 4 RBC, 4 FPP and 4 platelets. So what they do, they first transfuse the platelets, then transfuse the FFP and then transfuse the PC. But remember one thing, blood transfusion is not the alternative to the definitive hemorrhage control. Role of tranexamic acid, 1 gram of tranexamic acid bolus within 3 hours of injury and another 1 gram over 8 hours by infusion, which was also done some crash 2 and 3 trial, which was suggested there is a decrease in the mortality if tranexamic acid is given within 3 hours of injury. So our patient was having a massive pneumothorax, rapid accumulation of more than 1,500 ml of blood, usually common on the left side due to blunt trauma, aortic injury, penetrating injury to the major vessel. Severe blunt trauma will cause a rib fracture, plial chest. This rib fracture and plial chest is going to injure the lung paragonal vessels also and intercostal vessels also. So when if the bleeding from the parenchyma or a intercostal vessel, there is not, you will not going to have a thoracotomy because this bleeding will going to stop due to the tamponade effect over period of time. But if bleeding is coming from the another major artery like pulmonary artery or some other artery, then you will require a thoracotomy. So this is massive pneumothorax. So blood, any pneumothorax, you can get away with the simple pneumothorax. If your simple pneumothorax, if pneumothorax is less than 3 cm, patient does not have a unstable vital sign, you can manage it conservatively. But every pneumothorax which is more than 300 ml should be drained via tube thoracostomy because this blood is going to stay inside the pleural cavity. It will be a needle for the infection or empyema, or it will create atelectasis. It is going to a blood loss, blood volume.
Patient ને injury છે તો એને કેટલી વારમાં હોસ્પિટલ આવી ગઈ?
20 minutes.
20 minutes. એને એક્સરે માં આટલું મેસિવ નહોતું દેખાતું.
નહોતું.
ક્વોલિટી સારી નહોતી.
Quality સારી નહીં, patient ખૂબ movement કરતું.
પણ સ્ટીલ એમાં ઘણા બધા એર બ્રોન્કોગ્રામ્સ હતા.
Air bronchograms.
પેલું નહોતું. પણ જે તમે બતાવો છો કે આટલું બધું હશે તો ત્યારે ongoing
Ongoing હશે. અને even we are starting the resuscitation and then we have started the resuscitation and bleeding was increasing.
Of course it will.
From all the bones. So when the need of urgent thoracotomy as per guideline, if we put the ICD and 1,500 ml of blood is directly coming. If blood is coming as a 200 ml per hour, persistent need of blood transfusion and color of blood is more indicated that this black color and red color we are going to do a thoracotomy. So our patient transiently responded to the fluid resuscitation. Immediately 2 PCV started. What we used to do in our setup, we used to transfuse group to group blood. Like patient is B positive, I will ask the blood bank to give me B positive group. Or you can ask for the O positive group if start with group to group without cross matching, and then you another while you transfusing the one blood, there will be another simultaneously 3 to 4 PCV are undergoing cross matching. But unfortunately in Baroda no blood banking is issuing group to group blood. Everyone is issuing after cross matching only. So we have waited for 30 to 45 minutes before any blood to come. Then patient was shifted to operation theatre. During operation theatre, right internal memory artery was also transected. Left internal artery memory was also transected. Both artery was clipped and ligated. We have done echo before shifting the patient to the operation theatre. There was no cardiac tamponade. And during OT also, Vipul sir opened the pericardium and there was no any injury to the heart. During operation theatre, another 2 PCU was required and 4 elective was also given. After repairing the defect, after doing the source hemorrhage control, patient was shifted to ICU around 3 am in the morning. Then patient was extubated next morning, and all drain ways removed on post of day 3, and patient was discharged on post of day 7. This was
right-sided hemothorax बिल्कुल no, right?
No, left side is what?
Right artery માંથી જે blood
Right
આવતું
artery.
ક્યાં જાતું?
Right artery માંથી જે blood આવતું એ most of the blood was coming outside.
Outside આવતું.
Most of the blood was coming outside from the
એરિટીમાં communicate નહીં થયું હોય.
So this was the second X-ray on the second day of operation, and this was the 5th day when the drain was clean. So conclusion. So systemic approach in trauma saves life. Oxygen, start oxygen each every trauma patient comes to you. Take IV lines, attach monitor, take vitals, control the accentuating hemorrhage, assess the airway and intubate if compromised airway. Assess for the tension pneumothorax, open pneumothorax, pneumothorax, and look for the external injury to the chest. Assess for the hemodynamic parameters and use E-fast and try to locate the site of blood loss. Early recognition of the shock and resuscitation with blood products rather than only resuscitation with the IV fluid. Assess the neurology by GCS exam. I have not included disability and environment exposure. Disability માં આપણે GCS જોઈએ અને કોઈ જગ્યાએ એસેસ એરવે બ્રીથિંગ સર્ક્યુલેશનમાં પ્રોબ્લેમ નથી, પેશન્ટ અનકોન્શિયસ છે, ઇન્ટ્યુબેટ કરી દીધું. ડિસેબિલિટીમાં we see for the pupil size અને less than 8 GCS we directly shift patient to the CT scan to rule out the iliac thorax and spine imaging. Spine imaging na some criteria is there, Canadian spine criteria. Okay, when to do X-ray in a stable patient, and if any patient comes to the head injury, it is dictum that you do the cervical spine X-ray or CT scan. Our hypothermia, our hypothermia comes in ABCDE, that environment and exposure, and appropriate transfer. If patient, so ATLS માં એવું બી શીખવાડે છે કે how to transfer this patient. So now this patient come to my hospital, I am not having a appropriate CTOD, that patient might ring a lung heart machine. So I will coordinate with the next hospital, that I will tell that I have a patient of 38-year-old male. Patient is likely to have a cardiogenic shock, hemorrhagic shock, possibility cause is massive pneumothorax. I have already taken 2 large bore vessels. I have already started 2 PCV, and this patient will require a urgent thoracotomy. So I am shifting this patient to your hospital. So the next hospital knows that this patient is coming and what we are going to do for this patient, and the hospital will be ready to manage this type of patient. So that also explain you how to do a